everyone. My name is Maya Luria with TMC for Seniors, and we are continuing on with our Women's Health Month. And today is a really fun topic. It's all about everything your mother never told you, women's pelvic health. So I have Samantha Johnson here with me today. She is a physical therapist with our TMC Outpatient Therapies, and she does pelvic floor rehab. And so she's a great person to share with you all you'll need to know. So I'm going to go ahead and put your presentation up. You may be watching us today on our YouTube channel, or we also have a small in-person audience. If you have any questions, please feel free to put them into the chat for after the presentation. So welcome, Samantha.
Thank you. Thanks for having me again. All right. So yes, I am the pelvic floor physical therapist that we have right now here at TMC. And part of my presentation is going to include some information about how to come see me if you find that is something of interest to you. But for now, let's go with one of my favorite topics. I chose this title because this is a phrase that comes up quite a bit when I'm treating my patients this is everything your mother never told you about fill in the blank. So we'll talk about some of these things. And since this is such a broad topic with so many different things to talk about, I kind of picked some three common myths or three common things that I hear that comes up quite a bit. Sorry, I forgot to turn on my mic. Okay, so let's go ahead and get started with that. First of all, I wanted to talk about the anatomy. So I can probably hazard a guess this is probably something most people's mothers never actually told them. A lot of people have cutesy little terms for the different body parts, but when you go to the doctor and then you need to try to talk to them and explain what's going on or where it is, it's a little hard, when they don't know whatever term that your parents might have taught you in place of these. So first of all, we've got the vulva. The vulva is the external genitalia. It's the inner and outer lips, or the labia, majora and minora. This is everything that if you took a mirror and looked down at the bottom of your pelvis, this is what you would be looking at. And it's hopefully color coded. I don't know how well you guys can actually see that. And this is another thing that if you've never taken a mirror and looked at what's going on, I highly recommend it, because you might come in to see me and I'm going to probably have you do that and you want to have already looked. But it's also really important because there's certain things that you can learn that we'll talk maybe a little bit, we'll touch on some of those things, but these are certain things that you can kind of keep track of to see how things are changing as you continue to mature and get older. The vagina is the second term. This is a big pet peeve. This is one that we kind of use this as a catch-all term, and it's actually very anatomically incorrect. The vagina is the canal that's inside of your body that, like, if you're having penetrative intercourse, this is what is being interacted with. The external vulva, this guy, not the vagina. You can see the opening. We call it the introitus is the fancy word. This is the vagina. It's hard to see on this one, but back behind the bladder is the vagina. The uterus. Some people still have it, some people don't. The hysterectomy is becoming a little less frequent as we go on, but this is definitely something that comes up quite a bit. The uterus is the part at the top of the vagina. It's above your cervix. So we've got it with the blue area through here. This is obviously where the baby grows and where it matures. And this is when you have just a partial hysterectomy, this is what's being taken out. It's just the uterus, not the ovum or the ovaries. Okay, so now that we've got that cleared up, let's talk about what the pelvic floor is, because if you're like me, until I took my courses or until you come talk to me, you probably don't actually know what this is or have any idea what it actually looks like. Your pelvic floor are the muscles of bowel, bladder, and sexual function. They have generally what we call the 5 S's of function. They work sphincteric, which is of what we know a lot with incontinence. They help to support all of your organs and hold them up inside of you where we would like them to stay, ideally. They have a sexual function. So if you climax and you feel that nice pleasurable contraction of muscles, this is from your pelvic floor. You can thank those. They work as a sump pump. So they help to keep all of your blood flowing so it doesn't just accumulate down in the bottom of your pelvis, which can create some other issues. And they actually also serve a really large role in your stability. These muscles make up the bottom of your core. Your core is not just your six pack. That's actually not even part of your core, in my opinion. Your core is your abdominals, your diaphragm, your pelvic floor, and the muscles on your back, including your latissimus dorsi, your swimmer's muscle, and your glutes that make up your butt. So this muscle then obviously works with those core muscles to help you with posture and breathing even. It works with your diaphragm like a piston, the two move together. So if you're holding your breath quite a bit, you might be having some issues with your pelvic floor too. These are some common complaints, and I've mostly included this slide because I know I'm not going to cover all of these topics today. And if this is something that your doctor's ever said to you and it clicks a little light in your brain going, oh, there's something I can do about that, I want you to see these terms so you know you can come see me for these things, not just the topics we're covering today. As far as bladder issues, we've got the incontinence, we've got frequency. Nocturia is when you have to pee a lot at night. Typically 0 to 1 times a night, but when you're over 65, we will accept even up to 2 times a night. I usually go with how much it bothers you having to get up. Bowel issues. I do work with the bowels, not just the bladder. Constipation, fecal incontinence, where you lose a little bit of stool. Fecal smearing is where maybe you just see a little bit of feces in your underwear kind of smeared in. Fecal urgency, having to run to the bathroom to empty your bowels. Pain with bowel movements and or hemorrhoids. And then the sexual issues and pelvic pain, I kept kind of small because this is where we can really go down rabbit holes if we want to. But in general, if you've got a pelvic organ prolapse, you've been told your bladder has dropped, your uterus has dropped, your rectum has dropped, or you see or feel a bulge in your vagina, I'm the person you talk to with that. Dyspareunia, I already had a question about, that's pain with intercourse. And that's, again, kind of a catch-all term. There's a lot of different things with it. Vaginal atrophy. As we get older, our skin changes. Think about how the skin on the back of your hand has changed over time. It's got a little bit more fragile, a little bit more easily damaged. It's a little drier. You've got to take a little more care of it. Same thing happens with our vaginas. And I do mean vagina, not vulva, but part of the vulva too. As we get older and we lose estrogen because we go through menopause, we start to lose that hormone, the estrogen, that is what drives the tissues of our vagina and the inner vulva, the labia minora. So you might start to notice some changes. Again, that's where you take your hand mirror and you take a peek and see what things look like. So in 5 years, you can take a peek and see again. Peripartum issues, this is, I don't think is pertinent for this crowd. I don't want to make any sort of assumptions, but this is kind of directly surrounding delivery and pregnancy. So that is something that I do treat as well. Okay, so let's get to the fun stuff. So I've got about 3 major myths that come across in my office quite a bit, but also just in general. These are things that we're told, or these are things that, it's just understood. So the first big one, this is probably the number one that I hear, is that it's normal to have some incontinence as you get older or if you've had kids. It's normal to pee your pants when you laugh a little bit. Do we think that is true? No. And the big important phrase with that is common does not mean normal. Something can be very prevalent. A lot of people have it, but that doesn't mean that's normal part of your function. And this is a big one. So for urinary incontinence, just a couple fun facts, maybe not so fun facts. This is the number 1 reason that women are admitted to nursing homes, is uncontrolled urinary incontinence causing infections and that sort of thing. 44 to 57%, which is a pretty big gap, of middle-aged or postmenopausal women are experiencing some level of urinary incontinence. About 75% of women in nursing homes. Makes sense. And then this is from a course that I took back in 2017. So I don't know what the updated number is. I apologize, I didn't go look it up. But that's a lot of money. And most of that is spent on just assessing why you have incontinence, not actually treating it or managing it. What are some risk factors? Your age. It is. As we get older, our muscles don't function quite as well. We lose collagen, we lose some stability. It makes it a little harder for muscles to work. We get a little stiffer, so the muscles have to work harder in general. The number of pregnancies actually is. The more times you are either having a vaginal delivery or your abdominal muscles are being cut open during a cesarean delivery, the more those muscles are going to be impacted. As much as it's a beautiful thing and it's a joy to have children, it is a trauma to these muscles and to this area in general. Your birthing experience. So how long was your labor? How hard did you have to push? How big was your baby? Did you have to have forceps? Did you have an episiotomy? All of these things can have an impact. and don't ask because I don't remember which ones have the most impact, but the more trauma, I think the more likely it's going to have an impact on you. Menopause, that's why you're here. So obviously we just talked about the tissue changes a little bit that happens with this with vaginal atrophy, and we're going to talk about that a little bit more in another slide. Hysterectomy. If you take out that uterus, it's a space filling organ. It's pretty big, it's pretty solid. It's got a lot of ligamentous attachments to it that help to hold all of your organs up and in. And when we take that out, we lose those attachments that hold everything up and in, and now everything's going to come down and fill in that space. Once things start traveling down, unless you do something, they tend to keep traveling down. Obesity is another big one. If you think about any additional weight that you have on your chest or on your stomach, it is going to apply pressure to your organs and to that abdominal cavity, and therefore your body's going to have to work a little bit harder to manage that. And it's also just the pressure in general. Our body works on pressure gradients. The more pressure I have, the harder my pelvic floor has to work to counter that pressure. There's different types of urinary incontinence, and this is more of just if you are looking for a referral and you're trying to describe what's going on to your doctor, I want you to have these words too. Stress incontinence is that when I cough, laugh, sneeze, jump, pick up something heavy, move suddenly, take a weird step off a curb, and I have a little bit of a leak. That's what stress incontinence is, not, oh my God, I'm feeling anxious and stressed out. Urgent incontinence is, oh, I get to the door and I try to unlock my door, and all of a sudden I really have to pee and I can't control it. Or I hear running water and I have to pee and I can't control it. That's urgent incontinence. Overflow incontinence is that my bladder is just too darn full. There's nowhere left. The bladder does not stretch infinitely. It has a maximum capacity. And if you wait too long, you can get overflow incontinence. I don't care how strong your pelvic floor is. Mixed incontinence is a combination of typically stress or urge. Obviously, if you're just waiting too long, it's not necessarily something I can address. That's maybe something that you have to work on your own. And then just a note, these do describe, it's a symptom-based description. It's not indicative of any sort of pathology. So if you're being diagnosed with an incontinence, typically it's more of this is a symptom of something else. All right, some management strategies. So there's a lot of different things. Everybody already knows the liners and the absorbent underwear like Depends. Those are really common ones I see. They're great. They're easy to get to dispose of. You don't have to worry about it. You just bring a couple extra with you. Unfortunately, if you're not constantly having a large amount of urinary incontinence, it is going to suck some of the moisture out of your skin. So for some people, it can be a little bit irritating. So there's some other options. Poise Impressa is an internally worn device that essentially just applies pressure to the back of the urethra, the tube that allows urine out from the bladder to the outside of your body. And it just helps apply that pressure. Again, everything works on a pressure gradient so that your pelvic floor doesn't have to work quite as hard, especially if there's something going on with that muscles that means they can't work as hard as they need to. Maintaining adequate fluids. This is kind of a sub everything your mother never told you, and also a really common pet peeve. If you restrict your fluid because you are afraid of peeing your pants all the time, you are going to increase your urgency. You're going to make yourself dehydrated and your urine is going to be more concentrated. Your bladder tissues do not like that, so they are going to tell you to go to the bathroom a little bit more frequently to try to get that out. And then you're going to get frustrated because you go to sit down and the urgency didn't match what came out, and then it turns into a vicious cycle because, as some of my patients may know, I always say your bladder is a puppy, and if you train it to go all the time, it's going to start having to go all the time. So we want to manage that. Smart hygiene. This is the part that inspired me for the title of this, because these are the things that I call this handout that I have for my patients called Everything Your Mother Never Told You About Taking Care of Your Vulva. Don't put soap. Soap is okay on the outer parts, the parts that have hair. Totally fine. If it's on kind of your abdomen or right above, totally okay. Maybe use a scentless soap that's not as irritating. Do not put it on the inner lips. Do not put it in your vagina. It is okay for your vulva and your vagina to have a little bit of an odor. If it smells bad or fishy or you're uncertain about it, talk to your doctor, especially if there's a change in the color of anything that might be coming out. Cotton underwear is great, breathes a little bit better, and making sure you change after you've gotten really sweaty, like with exercise or if you've had a decent amount of incontinence. And then, of course, physical therapy. Shameless plug. All right, myth number 2, it's normal to have pain with sex as you get older. Do you think that one's true or false? It's false. Okay, again, something that's common but not necessarily normal. Pain is never normal. Pain is a sign of our body trying to tell us something and our body trying to keep us safe. Some common issues. The tissues lose estrogen. Again, think of your hand. The skin on the back of your hand is easier to be damaged. Same thing happens with your vagina as we lose estrogen, vagina or vulva. The atrophy that we talked about, the changes in those vaginal and or vulvar tissues. Fistulas or fissures. I asked myself too quickly. The fissures are typically more of a tear that happens right at the anal opening or near the vagina. And then a fistula is actually a canal that forms between typically the rectum and the vagina, which obviously can be a little bit problematic and can be quite painful. Lichens sclerosis or lichens planus are two diagnoses. I'm not going to go into detail with these, but these create a really, really painful irritation of the vulvar skin, and can lead to ulcerations and sores, and the vaginal atrophy and the vulvar atrophy can get expedited quite a bit. Prolapse, that's that when the organs start to come down. Obviously, if your bladder's in your vagina, then it's not going to feel great. Muscle dysfunction, if those muscles are tight or in spasm. And I think for the vast majority of women and even men that I see, this is your problem over the muscles being purely weak and loose and floppy, which I think is most of the time what we think is actually happening. If those muscles are short and tight, they are not strong. They can't contract any further. This is my pelvic floor, for those of you who don't know. It's a little easier to show you this. Okay, pain response to frequent infections. This is another big one that comes through. People come in and they say, I feel like I've had a UTI, or I feel like I've had a yeast infection, or I feel like I've had these things for months and it just won't go away. And when they culture my urine, it's clear. When they take a swab, it's clear, and I don't understand. Especially if you've had quite a few infections, your muscles can start to mimic those symptoms of infection just because they're tight and they're guarded and they're trying to keep you safe. Your muscles lose tone and strength over time. Again, these are kind of some of those age-related changes that happen just as we get older. Our pelvic floor's muscles, they're going to react just like the muscles in your arms or the muscles in your back or in your legs. It's going to be a little harder to use them. And the harder they are to use, the more painful they can be as a way to keep you safe. These are a couple more diagnoses that are really common. I think most of us kind of have an idea of what IBS is, that irritable bowel syndrome that can go either diarrhea or constipation. Fibromyalgia is that chronic pain condition where it's more of a full body sort of thing. And then interstitial cystitis is also called painful bladder syndrome, and it actually is really, really highly correlated with pelvic floor dysfunction. And your stress levels. If I'm stressed and I'm clenching my jaw or my shoulders are really tight because I'm holding a lot of tension, you're probably holding a lot of tension in your pelvic floor. I don't know if anybody can tell what this looks like, but it's actually a basket. And this is a great place for your body to store stress because it's a basket. So it's going to. Lack of lubrication is also another really common cause of pain with intercourse. Lubricants are your friend. Use as much lube as is necessary to make everything happy. Because when we lose the estrogen and actually testosterone, everybody thinks that's the men's hormone, but your body does produce some testosterone. Our tissues, that's part of what makes our tissues dry and dehydrated. General dehydration, I was going to say that anyways. If you aren't putting enough moisture in your body in general, everything's going to dry out. We live in the desert. I think we are all aware of this. Same thing is true for our vaginas and our vulvas. Arousal dysfunction and non-concordance. So non-concordance is a really big word that means up here, you're really into what's going on. This is fun. We're having a good time. Your vagina did not get the memo. So you can be really into whatever you're doing with your partner, but you might be having some issues with dryness because for some reason your vagina or your vulva is just not responding the same way. Sometimes it just takes more stimulation than it used to. Sometimes we lose the nerve conduction, especially for people that have diabetes. This is one of the big things that causes erectile dysfunction in men, is if they have diabetes. Just like we lose the sensation in our feet, we lose the sensation in our genitalia. Okay, so some management strategies for this. Topical hormone replacements. That's a little bit of a mixed bag. So obviously, always discuss this with your doctor. They know your medical needs better than I do. I also cannot prescribe these things. I might say, hey, if you're not on this, go talk to your doctor and see if this is something that's appropriate for you. If you have a lot of questions, or you remember, I think it was back in the 90s, there was a study that was published that said, huge link between breast cancer and vaginal hormones. It's been debunked. I do still, anybody that has a cancer that's related to hormones, I do generally tell them, go back and talk to your doctor about this, just to make sure that you feel comfortable with it and everybody knows you're on this. But this hot flash havoc that's on this red tile, I know that's kind of hard to read. I want everybody to write that name down if you aren't already on a vaginal estrogen replacement, because this talks a lot about it in the myths, and it talks about menopause in general. So it's a really nice resource. When you go to the YouTube channel, it's going to make that that screen that back when we all had the tube TVs and it was on channel 3 and it had that loud noise. It's going to make that you're on the right video. It's not malfunctioning. Vaginal moisturizers. So vaginal moisturizers are like a hand lotion, but for your vagina. They're specifically made for your vagina. They've got a good pH. They're not going to have irritating chemicals in them. You might have to find one that's appropriate for you. I have had some people that have had some sensitivities to some of the ones that you can just buy in the pharmacy. But think of things as a spectrum. If topical vaginal hormones is a long-term management for the hormonal changes that are happening with the dehydration and the atrophy in my vagina, and lubricant is for in the moment when things are getting hot and heavy, your vaginal moisturizers are kind of in the middle. You use them every 3 to 4 days as needed to just keep everything a little bit moist and happy in the way we want it to be, especially being in the desert, and especially if you have a hard time getting in enough water. Good Clean Love is a company that they've got a lot of vaginal products on the market, including lubricants and moisturizers. And they have a really big focus on research of making products that are really safe for you. So this is one that's kind of a gold standard that a lot of vulvar and vaginal experts will recommend to people. It's usually pretty good as far as not being irritating to you. Okay, we talked a little bit about kind of those arousal dysfunctions. So plenty of foreplay. Explore other forms of intimacy. Sex doesn't have to look like our traditional penis and vagina or whatever you're used to doing, okay? It can look like a lot of things. Don't skimp on the foreplay, don't skimp on the lube. These things are really, really important. If you're kind of going, well, what else is there besides penis and vagina, or I'm not very creative, or my partner's used to a certain level of intimacy, this podcast that I've got on here from The Daily, The Joys and Challenges of Sex After 70, was really, really nice. It's about 45 to 50 minutes long. And it has a lot of really great information about how things change as we get older, as we want to continue intimacy. Meditation and relaxation practices are really important. Again, remember, we talked about how those muscles can get really tight. And if you're stressed out, your muscles are going to be trying to protect you. Also, there's fight or flight mode. If you feel like you are being chased by a tiger in the savannah, then probably your vagina is going to say now's not a great time for procreation. And that's my analogy for when we're really stressed out, because that's originally what stress was developed for. So you want to manage those things. And this is something that if you have access to a therapist, or you've been thinking about seeing a therapist, this might be a really great way of doing it. And they can help you find the best way of doing this, because there are a plethora of different options. If you aren't sure about seeing a therapist, or you kind of want to do your own research on your own, this is another podcast that I like. It's called the Feminist Survival Podcast. So it's a little bit, I don't want to say liberal-minded, but very open-minded. The primary person on it, her name is Emily Nagoski, and she is a women's sexual health researcher, PhD. She wrote what I consider the Bible on women's arousal and that sort of thing, and what a lot of my colleagues consider the Bible. That book, if you want to write it down, is called Come As You Are, pun intended. And she and her sister have this podcast together. The first 2 episodes are fantastic. The first one's called Separating the Stress from the Stressor. Your stress is not always the thing that's causing you to have stress. So you might be really worried about bills or finances or retirement or whatever's going on, but that is not the physical manifestation that appears in your body as stress. So this has, first episode talks about that. Second episode has some research-based ways of helping you manage stress. Addressing the stress and stressors, there we go. stretching and strengthening your pelvic floor. So this is where I come back in a little bit. I wear a lot of hats. I dabble in a lot of different areas because we are not just our pelvises. We are the sum of our parts that are attached to our pelvises, including all the thought processes that happen here. So I dabble in a lot of these different things, but this is really where my role is. I'm teaching you how to appropriately stretch and strengthen your pelvic floor because, again, short, tight muscles are not happy muscles, nor are they functional. Medical management for related issues. So this comes back to those diagnoses like the IBS, interstitial cystitis, and that sort of thing. Okay, going a little slow, so I'm going to speed up a little bit. This was kind of an interesting one. I actually heard this one from one of my coworkers. I haven't seen this one clinically, but I thought it was great to add so we could talk about prolapse. Running too much or working out too much will make my uterus fall out. I'm not even gonna make you guys guess on that one. This is a common thing that I talk about with my patients. Prolapse is not either in or out. It goes in different grades. I'm not legally allowed to formally grade these, but I do have a grading system that I've been taught through my courses that helps me communicate with your doctor if this isn't something that's already been identified for you. And this picture, it's a really nice, don't stress out about it too much about making sure you've memorized it or anything, but this talks about the different types of prolapse. The cystocele, which is your bladder, the rectocele, which is your rectum, obviously, the uterine prolapse, and then you can, if you don't have your uterus anymore, you have what we call vaginal vault prolapse, where the top of your vagina that's not just open to the inside of your pelvis collapses down in. Intercourse, you don't want that. That's different. That's a medical management. You don't want that one. And that's kind of my bottom point there. If you have a very high grade of prolapse, what we call a 3 to 4, 3 is where it comes out and then it can come back in the right scenarios. 4 is where it comes out and stays out. And then that enterocele, which is your intestines dropping down into the space at the back of your vagina, those are surgical management. I can't help you a ton until that's already been taken care of. If your prolapse isn't very severe, I am your person to talk to. And then to a degree, we just don't know because this is all relatively new. There's a certain amount of drop that might be just your normal. So if there's like a very minor grade 1, I wouldn't stress out about it too much unless it's problematic for you. What is problematic? Some of these symptoms. You see or you feel a bulge in your vagina. Everything feels really heavy or there's a lot of pressure. Bleeding or discharge or infection, because if you can imagine, if I have organs that are coming down and now my vaginal tissues are on the outside and they were never made to be there, they're going to get really irritated really easily. Low back and sacral pressure. So this is your sacrum. This is your tailbone. Your tailbone is the little teeny tiny spit off the bottom. Your sacrum is the big piece that the rest of your hip's attached to. So if you're having pressure in those areas or just kind of a general back pain that doesn't really seem to change, maybe gets worse at the end of the day, you might want to get checked for a prolapse. If you have to use your finger to either apply pressure to the outside of your perineum is my fancy word for this external genitalia. If you either have to apply pressure or you have to insert a finger or a thumb to allow yourself to empty your bladder or your bowels, you might want to get checked for a prolapse. Symptoms that are at night is a bad choice of phrase on my part. If your symptoms are worse in the evenings or after long days, you've been on your feet a lot, or as you've just been upright more, you might want to get checked for a prolapse. Worse after you've been straining or after you've been doing a lot of really heavy lifting. I get this when I'm doing a lot of rock climbing. This might be a sign that you need to get checked for a prolapse. Slow urinary stream, or as you get done and you go to stand up and a little bit more dribbles out, might be a sign. And if you feel like you're just not emptying your bowels or your bladder efficiently, you have to strain. Conservative management, again, physical therapy. There's supportive garments that you can get that apply pressure. Unfortunately, I didn't include pictures, I apologize. Pessaries are, again, things that are worn internally to help fill that space in the vagina and keep everything up where we want it to stay. Weight loss if appropriate. Learning proper mechanics, especially if you hold your breath as you're lifting. Remember, diaphragm, pelvic floor, work like a piston together. If you have to kind of like lean forward to get a little more urine out, that's actually a thing. I call it doing the hula as you're sitting on the pot. You're gonna move around and that's gonna help to empty. Splinting is a legitimate technique, and there are tools that you can buy to make sure that you're not straining as you're having bowel movements. And I think we kind of covered what you want to avoid. The straining for bowel movements, stay super hydrated, eat a high fiber diet so that you're not constipated, so you don't have to strain. Valsalva is when you hold your breath as you're doing something, or I hold my breath and I bear down when I strain. Abnormal posture with rounded shoulders and flat back. I think this is all a position we recognize from our grandmas, right? This is going to increase the pressure down into your pelvis. Okay, so I'm going to kind of blow through this a little bit because I want to allow time for questions. This is how you can come find me and what we will be doing. So you have this information. So I'm just going to give a general synopsis of it. What is PT going to include? Think of it like a buffet. All of these different options that are things that I can cover are great. They're really important so we fully understand why your body's doing what it's doing and why you're having the symptoms you're having. But none of it is required. If you come in and say, I would be endlessly uncomfortable with taking off my pants in front of you, we don't have to do that. However, I tell everybody, if you came into me with shoulder pain or neck pain, you would be a little confused as to why I never looked at those things if I didn't look at them. The same thing goes with the pelvic floor. Okay, what does it include? The pelvic floor assessment. I tell all of my people with vaginas, it's not as bad as going to the gynecologist. I love my gynecologist. She's great. She sends me a lot of patients. I try really hard to make it more comfortable. My table, it has no stirrups. I don't use a speculum. If I'm doing any sort of internal assessment, I need to feel. I don't need to see. I need to feel what those muscles are doing. So we do this digitally. And thankfully for everybody, especially my gentlemen, I have very small fingers. I have real cloth sheets. That's my favorite part. We're going to start with a visual observation of your perineum. I want to check for those changes with the atrophy. I want to check to see if there's any particular reason why you might be having irritation that's contributing to pain. And I also want to see if potentially there's an immediate visible prolapse, because that might direct how, me saying you need to go back and talk to a gynecologist or a urologist or that sort of thing. We're going to touch all of those muscles. We're going to palpate them, starting on the outside, touching on the inside. Short, tight muscles are weak muscles, and they also are typically painful muscles. Sometimes you don't know they're there until I touch them. I find a lot of painful areas that even if you're not having pain with any sort of penetration, I can often find them. And then if appropriate, we're going to teach you how to do Kegels. Kegels are not all created the same. So as I'm doing that assessment, I'm going to have you do a series of contractions, squeezing as tight as you can, holding as long as you can, doing as many as you can, so that I can see exactly what sort of Kegels you need specifically to manage your issues. And initially, for some people, it's no Kegels. Sometimes it's diaphragmatic breathing because the pelvic floor and the diaphragm are connected. The other thing, I call this the everything between armpits and knees. So in general, I'm also going to make sure that we look at all of the muscles that exist between your armpits and your knees, because they all attach to your pelvis. I think there's about 36 different muscles that attach to your pelvis outside of your pelvic floor. That's a lot of muscles that can impact how your pelvic floor is functioning, especially if there's something wrong with them. We're also going to look at your abdomen and breathing. Forgot to replace my picture from the men's, but if you sit up and it looks like a wine bottle is about to pop out of your abdomen, or you feel like there's a big gully down in between your abdominals, that's called Diastasis Recti or Diastasis Recti, depending on who you talk to. That's a sign that there's something going on with our core muscles. So that's another thing that I generally look for. I'm not going to go through this too much. These are some other options: exercise manual techniques, breathing mechanics, assessment of your body posture and your movement, a lot of education, if you didn't already guess based on how much I talk about this, and then biofeedback, either with me having my finger vaginally or externally that you can squeeze and you can feel, or using the computer with electrodes that are attached to your skin. Those electrodes are going to be placed perianally, so either on either side of the anal opening. You've been warned. That's the part everybody hates the most. Okay, so and I'll let you guys kind of peruse this on your own too. This is how to do a Kegel. Now remember, Kegels are not appropriate for all people all the time, and it might be that you actually need to learn how to relax your muscles first. So take this with a little bit of caution. If things don't get better, stop doing your Kegels. Get a referral, come in and see me, or learn how to relax those muscles if you can find a great way of doing it on your own. In general, Think of those sphincteric muscles, right? They're on-off switches, so we're thinking about stopping urine. We're thinking about not pooping our pants. We're thinking about not tooting in an elevator, okay? Those are the muscles that you're looking for. Don't stop and start the flow of urine. My biggest pet peeve. This is one that is all over the internet. Some doctors will recommend this. Your pelvic floor and your bladder both have muscles. If your bladder muscle is contracting to empty your bladder, you want your pelvic floor muscles to relax. If you are contracting them when your bladder's emptying, that puppy, remember your bladder's a puppy, is going to be very confused about what you're asking of it. So please don't do that. If you can't figure out how to do a Kegel, it's okay to do it a couple times, but if you're doing it constantly, you're going to come into me with other issues. How long does this take? My favorite phrase that I learned in PT school is it depends, because it's always appropriate. Severity of your a history of surgery, severity and duration of your symptoms, general stress levels or health, your activity levels, how good you are with your homework, because I'm going to give you homework to do. Also, how coordinated you are plays a really big factor. If it's really hard to learn how to do an exercise, don't despair. We will find a way to teach you, but that does make things a little bit harder, unfortunately, for you. Typically, I see people once a week because it's what you do at home, in my experience, that makes the biggest difference. Sometimes if there's a lot of things or you've got a lot of time and my schedule's super empty and you want to come in twice a week, we can make that happen. It's not inappropriate. But I find my patients do just as well if they're really consistent with their homework that I give them at home. Yeah, and then generally, depending on what's going on, you might see changes really quickly, and sometimes it takes a little bit. How to get here, this is also on here. The phone number, I did have the phone number on there. And the fax number to send referral. These are your doctors that can send you here, essentially, as long as they are in charge of your general health in some way. They are appropriate. Your dentist, probably not. Okay, and then this is where I got my information and where I got my pictures. Ta-da.
So thank you so much, Sam. I do have a couple of questions I wanted to ask before you read into the audience there. Does pelvic floor, do pelvic floor therapy, does that look different over time, like based on your age at all? Or is it usually the same type of treatment depending, doesn't matter what age you are?
I think probably the easiest answer is it generally looks the same. One of the big things that will vary is if you are unable to lay on one side, I am not going to make you lay on that side if I can physically help it. If you are unable to lay on your stomach, we are not going to have you lay on your stomach. And again, unless we can't physically help it. There's some, if you can't be there, you can't be there. We'll work around it. But in general, it's looking the same. Maybe if you're not an athlete and you're not doing really high level sports, I'm not going to have you run sprints or anything. But in general, it does kind of look the same.
Okay. So what is I know you said it's sort of different for everyone. What's the average amount of, like, how often would you see a patient for what's a normal amount of time?
I would say in general, 6 weeks is usually kind of the shortest I'm seeing people. I would say that's on the really short end, and that's maybe somebody who only had really mild symptoms, and in general, they're already really physically active and have really good health. Pain symptoms are a little bit of a different story. I've got a patient that I've been actually working with her for over a year because there's a lot going on with that. But in general, I'm having most people discharged by week 12.
Okay,
That's
great.
usually on the long end.
And if somebody is already doing their Kegels and it's not helping, what other types of physical therapy do you offer for that?
Stretching. Stretching's a really big one. The diaphragmatic breathing is a really big one. There's a really nice device on the market that if you're kind of techie and you're good with your phone, it connects to your phone via Bluetooth called Perifit, Perifit. And I really like their program. I actually dug mine out of the drawer and used it again last night just to refresh myself on it because I saw they had new games. They have games. They've got, like, you fly a little bird around obstacles. And I really like it because it also has a practice mode where you can just practice your homework with your Kegels like that I might give you so you can see how well you're doing it. And it's got 2 sensors so you can make sure you're doing your Kegels correctly and not just like squeezing with your abs instead.
Okay. I just had another question come in asking about self-referring for treatment as a Medicare patient. You do need to go to a PCP.
So the question was about self-referral. In Arizona, we are a direct access state, but all of the hospital systems in Tucson require you to have a referral. It's just a CYA thing. We just want to make sure that you've been seen by a doctor to make sure there's no big scaries that are going on in the background.
Okay, so that's great. I am going to put your number up here as well, so that everybody has it, but they can call 520-324-7005, and I'm going to turn it over to you now for any questions in-house.
Okay, in-house. Who wants the first question? Nobody wants the first question. Anybody want the second question?
What's your name?
My name is Samantha Johnson, but I go by Sam. It's too many syllables otherwise.
And can you do the website that you just recommended, the app?
The app is called PeriFit, PERFIT, and it has a device that you have to buy that connects to your phone, and that gets placed vaginally.
If there's been a change in the stop and go thing about with when they want a urinary
Sample
thing, where the directions used to be let it go for a little bit, then stop so you can get a clean catch.
So that's a little bit different. So she's asking about clean catches if they're taking like a urinalysis sample.
Yeah.
Yes, that's a little bit different. That's kind of a one-off because with some urinalysis, they need to have what's called a clean catch where it's in the middle of your stream. And part of that's just because this is why women get so many UTIs is because we've got a really short urethra and it's really close to our vagina and our anus. And so it's easy to get bacteria up in there, which can, if they're trying to see, do you have an infection in your bladder? Obviously, we don't care if there's bacteria in your urethra. So you're going to use the initial part of your stream to empty out your urethra, stop, get your cup in place, empty out a little bit more. I always try not to overflow the cup. I'm not always successful. And sometimes I really have to pee. I was trying to prepare. But that's the goal there, is to get that middle of the stream because you don't want things to be kind of messed up by what might just be in your urethra but isn't actually problematic.
Okay. Well, I'm asking because I have the opposite problem of getting enough in the cup.
I drink a lot of water before those.
So, and I do have one other question, which is, if you don't have any of these situations, how do you keep the pelvic floor and that whole area in tone and good?
Kegels.
Just the Kegels?
Yep, Kegels are fine.
And the lubing.
And the lubing, yes. Okay. Kegels, I would say Kegels and diaphragmatic breathing. I want those to always go together. I actually, another health practitioner that I follow on Instagram posted recently and said that her recommendation is always you want to do double the relaxation that you do the contraction. So if I'm going to hold my contraction for 5 seconds, I want to make sure I've got 10 seconds of relaxation. Because it's really hard to tell if, again, this is my pelvic floor, if I'm relaxing to here, that's helpful, but that's not relaxing to here. And that difference is subtle and it's hard to feel. So making sure you're doing those, making sure you're being good about your posture, you're being smart about your workouts. If you're holding your breath and turning red in the face when you're doing whatever exertional activity, it might be too hard. That might be a sign there's something going on with the core. Yes, ma'am.
What does diaphragmatic breathing look like?
Yeah, it's so hard to show in standing, and I'm really bad at it.
Try it.
It's belly breathing. So I teach my patients to breathe in through the nose, out through the mouth. Sorry, the question was, what does diaphragmatic breathing look like? You're breathing in through the nose, out through the mouth. Your goal is not to breathe in your chest. So I always have a patient put their hand on their chest, a hand on the lower belly. I like to have people do, sorry, I'm going to move. I like to have people do a thumb on the belly button and their pinky on their pubic bone because this is the area I want you to breathe into. In through the nose. Maybe my chest rises at the end. I'm going to let all of that air out. Forget to ask the question. Yes, you. Yes. Did that help?
Yes.
Okay, good. Who else has a question? Yes, ma'am.
So when you talk about the skin, and when you said the skin in the back of your hands, I thought, oh Lord. Vaginal moisturizers. Any particular one?
An easy one to find, and it's a pretty solid recommendation, is Reclens. It's in the aisle with the yeast infection medications, and it comes in similar packaging, so make sure you grab the right thing. That Good Clean Love is another really good one. I think they're offering them at Target and Walgreens, last I checked on the website. Those are also good. Some people like using like a food safe or a food oil, like coconut oil, like a refined coconut oil. I'm always a little hesitant because coconut oil is usually okay. It's got some antimicrobial properties to it, but in general, if it's flavored or it has sugar in it, you don't want to put it in your vagina. You're going to increase your chances of an infection. But some people like doing more natural.
Somebody talked to me about aloe vera.
Aloe vera gel can be nice. There's a company I like called Fat in the Moon, and they make what they call Cooch Quench, and it's like a salve that you can apply. I forget what it's got in it, but it's got some safe oils in it too. Yeah, great questions. Anyone else? I'm so prepared for so many questions. No? Other questions?
So, Sam, I want to thank you so much for being here today. It was great to hear everything about everything your mother never told you. So, so thank you for covering this, and we look forward to seeing everybody soon.
Yes, thank you so much.
So if you would like to tune in for our next presentation, we will have the next one on Tuesday, March 24th, and that will be Is Your World Turning? All about vestibular testing at 2 o'clock on Tuesday, May 24th. Thank you all for being here. Take care.